Welcome to Mastering and Guideline in Ultrasound and Echo.
Hi everyone. In this lecture, we are going to do practically step by step how we measure stroke volume or mitral valve inflow, left ventricular stroke volume LVOT SV, right ventricular outflow tract stroke volume, and exactly how we can measure them. Those three measurements are more practical and useful parameters that we use in echocardiography. And just based on those measurements, we can calculate the amount of the regurgitation, stroke volume, cardiac output, intracardiac shunt, and so on. So are very important. First, let's see what is the continuity equation means. Continuity equation is a part of the conservation mass. Based on this principle, generally speaking, in any fluid system that is closed, like the cardiovascular system here inside of the heart, whatever come should go if we don't have any problem. If, for example, 50 milliliter blood passed through the mitral valve annulus to the left ventricle, during systole, the same amount should go out. Or on the tricuspid, the same amount. Pulmonary valve, the same amount. So it will be constant and nothing change if we don't have any valvular, especially regurgitation or intracardiac shunt. Now let's see how we measure flow or stroke volume in each of those passages. First, based on the physics, fluid physics, we can measure amount of the flow in any cylindric duct or canal just by measuring cross-section area of that duct or tube and multiple velocity of the fluid or gas at that level. Is very easy. So velocity of the fluid and the multiple cross-section area of that. But there is one problem, as you know, in the heart, the velocity of the blood flow during cardiac cycle, diastole or systole, is not constant. With the early systolic, it goes high, velocity go high, and finally get a peak and then drop. So it's not constant, it's parabolic. So for that, solving the problem and measuring velocity, that is mean velocity, we use it velocity time integral. That is a math formula that we use it. Instead of the velocity, we use velocity time integral in that specific spot. So if we want, for example, measure LVOT stroke volume, we just need measure cross-section area of the LVOT, and then we go with the pulse putting on the LVOT, and then we measure VTI of the Doppler by pulse Doppler. We calculated all those two parameters and finally get to the left ventricular outflow tract stroke volume. For mitral valve is the same. We go measure cross-section area of the mitral valve annulus, then do pulse Doppler at the same level, then we measure VTI of the mitral valve, and finally it gave us mitral valve stroke volume. For cross-section area is the formula for any cylindric passage or orifice is this formula, cross-section P square radius, that instead of the P we can put the number 3.14 multiple. Instead of the R we can use practically diameter, because the measuring radius will be hard in cylindric, finding the center of the circular area. So we measure easy diameter, then instead of the radius we put diameter, and if we calculate this one, finally cross-section area can measure by 0.785 multiple diameter square. In that case, very easy. We can put, instead of the cross section, this formula in here or here, then we just will measure diameter, we will have cross-section area of that spot. Now let's see practically how we measure stroke volume on each of those spots. For LVOT stroke volume, we have to go get first on the plaques, and then when we have correct image that I explained what is the correct image has criteria, then we go at the usually end systolic, but doesn't matter mid systolic or end systolic or any spot that give us the largest LVOT diameter. I explained in another lecture, you can go check it out. If you are not sure which spot is largest one, go measure in all those spots and see which one was highest, then go measure at that spot. That will be your LVOT diameter. Sometimes you have to go off axis, lower, higher, heel toe until you see more clear, complete largest diameter of LVOT. And if you use CAL, machine give you LVOT area as you can see here. Then we go apical 5 or 3. Doesn't matter which one, as long as we can make it our cursor parallel to the LVOT and direction of the blood flow at the LVOT. If it's the blood flow at with the color Doppler you see is this way, you are off axis. You will underestimate your LVOT VTI. You have to with heel toe or going lateral or apical tree, make it as much as possible your cursor parallel to the LVOT direction of the blood flow. Then the envelope give you, as you can see here, many times we have bit to bit variance, means envelope in each of the bit is a different size. Even the patient has regular bit almost. So in those cases that the envelope is too much differences, you have to measure all those and machine give you average of the VTI. And if you use CAL in the machine measurement or CAL pack system, machine automatically give you stroke volume. If you didn't use that one, you can use this formula. As you know here, this formula, and calculate the left ventricular outflow tract stroke volume, or in most, or we can say left ventricular stroke volume. For mitral valve stroke volume or mitral valve inflow rate, we go apical 4, put the color on the mitral valve, determine the direction of the inflow jet, because it's the same as principle. For any kind of the Doppler, we have to make our cursor is parallel to the blood flow at that spot. So when you do apical and then zoom on it with cine loop, find the hinge of the mitral valve or annulus of the mitral valve. As you can see, bending or moving around the valve, this spot and this spot we call hinge. So that will be those two spots that you are going to measure as a mitral valve diameter in the machine CAL system, CAL pack. You selected mitral valve diameter, then you go at the mid diastole, and then hinge to hinge with zoom in view here, hinge to hinge. That will be your mitral valve diameter, and machine give you automatically area of the mitral valve. Then you go the same view, make sure your cursor is parallel to the mitral valve inflow, put sample volume exactly at the same spot that you measure mitral valve diameter at this spot. Center of that almost the center that blood goes to the left ventricle. If there is calcification, still you can see the hinge with those wedge shape of the left ventricle and mitral valve junction here. You can see even if it's calcification, you can determine your annulus. Doesn't matter a little lower or higher. The most important, when you do pulse Doppler on here, you have to put exactly your sample volume at the same spot that you measure. Then you go trace it, your mitral valve inflow pulse Doppler envelope. If his respiratory variation is there, bit to bit variance, so you measure all those envelope and machine give you average, and finally the stroke volume of the mitral valve, as you can see here. For right ventricle outflow tract stroke volume that we use many times instead of the mitral valve inflow, especially when we have significant mitral valve regurgitation and we want to evaluate the aortic regurgitation volume, we use RVOT stroke volume instead of the mitral valve inflow, or in those cases we want to check the intracardiac shunt. For that purpose, we go PZAX. At the PZAX aortic valve level, when you got that one, we twist a little more clockwise. We open the pulmonary artery and make sure we can see clearly pulmonary valve ring, as you can see here. We just twist a little clockwise more, and even you can see bifurcation of the pulmonary artery. So when you have that, you pause it, you go loop, and then during mid-systolic or end-systolic, whichever is highest diameter, at the pulmonary valve ring, then you measure the diameter. When you measure diameter, machine give you the area of the RVOT. Then at the same view, we put pulse Doppler exactly, pulse wave Doppler at the same spot, make sure it's parallel to direction, then it give us envelope. When we have envelope, then we measure VTI of the RVOT pulse wave Doppler. Then machine automatically calculate for us stroke volume of the right ventricular outflow tract, or RV. If we didn't use cal, we can use this formula. Based on those numbers putting in this formula, we can come to the right ventricular outflow tract stroke volume. Right ventricular outflow tract volume, or we can call it QP, pulmonary flow. And with this formula ratio, systemic flow to the pulmonary flow, these two ratio, it gives us if there is an intracardiac shunt, right to left or left to right or not. In the normal situation, this ratio should be 1. If we have a right to left shunt, as you can see here, this ratio increase more than 1. If we have left to right shunt, and you can expect flow in the pulmonary system increased, and this ratio become less than 1. It's very simple as this one. Just for making professional and more accurate for those stroke volume measurement, I strongly recommend all of you go when they have a good patient and doesn't have any abnormal, not severe, or have only trace mitral regurgitation or tricuspid or pulmonary regurgitation or aortic regurgitation, trace. Use those, or if the patient doesn't have any of them, much better, and practice all those 3 measurements and see how much you are close. All those numbers should be almost the same. 5% difference between them is acceptable because bits to bits difference, and in that case you get know exactly where is your mistake, go fix it until you become professional and sufficient in the measurement of those stroke volume in each of those spot. In that case, this measurement help you in many situations, especially valvular regurgitation and stenosis, intracardiac shunt, and so on. We are done. I hope you like it. Up to the next time. Have a wonderful time.